So the first lecture is on aesthetic gynecology. It's overview of the field of aesthetic gynecology, and we'll talk about definitions, terminology, history, global landscape, why this field is growing, and what we've spoken about World Cup. One interesting fact. It applies in a lot of female sports as well, but there is an athlete in the current World Cup who is going to be in his 6th World Cup. It's a Mexican goalkeeper. So this is unbelievable because it's how many years of the professional sports, and he's still one of the best in the world. And that comes to also all the rejuvenation medicine, because you have to, besides your lifestyle and so on, you use all kinds of help to perform at a level that you used to perform 6 World Cups ago. We'll also talk about evidence and lack of it, and future trends. I've got no conflict of interest whatsoever. I'm not paid to do this by any company. BTL is a sponsor of this workshop, as well as SAPAS. And does anyone know SAPAS? So it's a lab, and they compete with PEFCE and MPAS. They're much smaller. They've started in Umtata, and all over the country. They do lots of histopathology, frozen sections, as well as all your lab work. And I know them from East London. So all the pictures and videos, it's my own patients, and they've all signed consents for material to be used, but we can't distribute it. You've received all the lectures, but please just don't use the photographs, and it's all only for your own use. Equipment has no endorsements from me. However, you will only see certain equipment. We only can show you one of radio frequency, one of laser. Laser is not even here. They're not sponsoring. BTL is here, and the device that we will be using from them is Exilis, and the alternative to that is newer device, which is Axion. And most of my clinical experience comes from those devices, as well of my staff, because we have not used anything else. So aesthetic gynecology, it's elective interventions to alter the aesthetic appearance of the external genitalia and modify the genital organs. And this is a definition made in a terminology paper published by International Urogynecology Association in 2022. And I was part of the working group to develop this terminology paper. Functional procedures or elective functional procedures are performed in the absence of pathology with the goal of improving patients' quality of life and sexual well-being. So if something is done for functional reasons, it's to improve some kind of function of the person, but not necessarily because they have a disease that is classified. Aesthetic gynecology has been practiced for centuries. One of my patients yesterday was telling me, or asking me, did I hear about pomegranates that were inserted vaginally for prolapse in the past? And I did not hear of it, but I know of hot stones that women used to use for vaginal tightening in ancient times. So it's not a new field. There is no new experiences that we are having. Women had those experiences for hundreds of thousands of years, and it's been documented. We know that in Egypt, in papyrus papers, there is description of herbal vaginal treatments. Hippocrates described pessary use. Serranos of Ephesus' first systematic gynecological text was published by him, and it's described external genital procedures. In medieval times, Al-Bakassis, Arabic surgeon, described repair of obstetric perineal injuries in Al-Tasrif, and Ambroise Paré, French surgeon, described advanced soft tissue repair following childbirth, which would be your vaginoplasty currently, which has a more interesting and exciting definition for our patients. In the 19th century and early 20th century, Marion Sims pioneered repair of vesicovaginal fistula, and that was also a foundation of the reconstructive techniques used nowadays. Howard Kelly and Johns Hopkins established modern pelvic surgery, and in 1971, the first peer-reviewed labioplasty paper was published by Martinichik and Malinovsky. And in 1978, there was a first European report on labioplasty. In 1984, Hodgkinson and Haidt first labioplasty performed for purely aesthetic reasons and no functional issues. And James Bart, have you heard of the surgeon? So he is quite famous for performing numerous operations of women without reasons and consent. And, and he even published a paper on the subject, but eventually his license was revoked. This is sorry, the names that you have to know, and well, if you practice aesthetic gynecology, David Matlock is quite famous for, he's a plastic surgeon, and he had a patient who was coming for some kind of cosmetic procedure who complained of vaginal looseness, and he decided to perform vaginal repair on her, which was called vaginoplasty by him, and it had a great success. She sent a friend, and he is a businessman besides being a plastic surgeon, so he trademarked the word vaginoplasty or laser vaginal rejuvenation. However, that laser vaginal rejuvenation in this case was a surgical vaginal repair performed with the use of the laser for cutting. So when people come for the vaginal rejuvenation thinking they're going to get laser treatment, it's two different things. So one has to be careful what they're asking for and what we are offering and what they actually need and going to have best outcome from. David Matlock had a TV show, his wife on the show as well. He did surgery on her, so he's quite famous in the marketing of aesthetic gynecological procedures. Dr. Alter, he works in Beverly Hills and also in New York, and he actually published the peer-reviewed labioplasty outcome data in 2008. Michael Goodman, he's a leading researcher, has published multiple reviews on female genital cosmetic surgery, and he's a founder of Top Cosmetic Gynae, so also provides teaching and online teaching. Ellen said, a urogynecologist, performs quite a lot of vaginal and vulval surgery, cosmetic gynecological procedures, and he is famous for performing vaginal repairs or vaginoplasties in the office setting. Dr. Bader runs ESAG. ESAG, European Society of Aesthetic Gynecology, started about, I would say, 10, 12 years ago. He's a gynecologist from Greece who qualified in UK and decided that he wants to study aesthetic gynecology, went to States for a couple of years, learned from all of those specialists, and then came back and started European Society of Aesthetic Gynecology. I've attended his courses, and yes, it was good. Miklas and Moore, also urogynecologists, they work in Atlanta, and they perform numerous vaginal vulval surgery, and they're good specialists. I think they're also authors of a couple of textbooks in the field. there is plenty of societies of aesthetic gynecology that have been established decades ago in various countries. I think my biggest surprise was how old is the Polish Society of Aesthetic Gynecology and how big it is. I come from a very similar environment, but I've never heard of one in Ukraine. And now it's a big field, but not in the past. But Polish Society has been around for a long time. Okay, I think I'm on the next slide, yes. So I've just mentioned a few, but there is plenty, and most of the societies run courses. You will have references to all of them. So when you were looking at Dubai, so it could have been American Board of Cosmetic Gynecology that runs courses in Dubai. Could have been other international cosmetic gynecology society. There is two main meetings, which is run by European Society of Aesthetic Gynecology. They usually call it World Congress, once a year, and another meeting is generally in Florida by International Society of Aesthetic Gynecology. It's usually in March. And the college's professional bodies, so the societies is a group of people, doctors. It's not really, I don't think anywhere in the world cosmetic gynecology is a recognized field which has exams or a particular certification. French do run a course as a part of university course in aesthetic gynecology, which goes over it's like a year or two part-time module. But it's not a recognized field. There is no subspecialty. Maybe there will be in the future, but not currently. However, majority of obstetrics and gynecology professional boards issued guidelines or statements or opinions on the various cosmetic gynecological procedure. And it's important to know what's available. So all of those colleges, American Royal College of Obstetrician Gynecologists in UK, Australian and New Zealand, Canadian, international has guidelines. HPCSA does have guidelines on aesthetic procedures that were published in 2022. And International Society for Study of Vulvovaginal Disease has a couple of statements as well on the use of energy-based devices in aesthetic gynecology. So this is just society running different courses, as I mentioned, in various countries. SAGS was established in 2018. We've done over 10 workshops. I've lost the count really, but we can count probably around 16 of them. We generally allow doctors to attend the workshop and not, so if you're not registered with HPCSA, we won't open the doors. And we are affiliated with ISAC. So this paper, the terminology paper, is quite important because it's one of the basically papers that actually recognizes what is being done and describes it in the terms that can be used then in your documentation, and also standardizes terminology for research purposes. So when the papers come out, when we are setting up some type of research project, we then can have something, all of us have something to fall back onto in terms of terminology, and then being able to comparing the results and outcomes. This terminology papers looks at all the procedures and classifies them as either reduction or tightening, augmentation, amplification or depigmentation. We've got surgical reduction or tightening, and that would include labioplasty, vaginoplasty, hymenoplasty, clitoral hood reduction or labia majora reduction. I offer all of the above except the hymenoplasty. I just simply refuse to do it, and it's really not a legal procedure. It's not possible to determine if someone is virgin or not by looking at the hymen. Hymen has all kinds of shapes, and it's really an unnecessary risk for a client. When I started practicing in cosmetic gynecology, I did not just refuse, I was open to discussion. But I had never done one, because anyone who came for a consultation to me did not end up booking the procedure. And those consultations take a lot of time. So I've decided at a certain point that I just don't have time in my calendar to do so, but it's a personal choice. Energy-based devices is the next category, and we have lasers, radio frequency, HIFU, and the next, I'm missing something here, I think, yeah, HIFM as well. And in terms of lasers, there is different type of lasers, CO2, YAG lasers, substances in injectables. So currently it's platelet-rich plasma, hyaluronic fillers, fat transfer. Exosomes is the newer ones that are also coming in, and they've been used in gynecology quite widely around the world. So female genital cosmetic surgery is umbrella term for elective surgical procedures on female genitalia for cosmetic purposes, including labiaplasty, vaginoplasty, hymenoplasty, or G-spot amplification. Genital rejuvenation is non-surgical and surgical procedures aimed at restoring or enhancing the appearance and function of the genitalia. And vaginal tightening or vaginoplasty procedures are performed to narrow or tighten the vaginal canal surgically or via energy-based devices. And labiaplasty is a surgical reduction or reshaping of labia majora or labia minora. So why is this field growing so fast? Many reasons. First of all, global life expectancy has been increasing year by year, and it's currently sitting at about 76 years. For South African women, it's 72. The life expectancy in Japan in women is now 87. More than 30% of time women spend in menopause. The average age of menopause has not changed. It's about 49 to 51 around the world. And genitourinary syndrome of menopause affects more than 50% of postmenopausal women. And those symptoms demand treatments, and women are not being simple treatments don't always work. So the other treatments, alternative treatment, are looked for. There is a huge shift in the quality of life expectations, and people definitely shifting from medically required to wanted quality of life centered care, where we can improve the minor symptoms that are not going to change or treat particular illness, but improve their quality of life. Sexual well-being is a mainstream women's health, and we have a talk on sexual dysfunction, so I'll cover it there, but women live till 80, 90, and generally we know that people only stop having sex about 5 years before they die, because in those 5 years their health deteriorates. So that means that they will be having sex potentially for 20, 30 years in menopause, which will require support from us. There is a huge social media drive on vaginal rejuvenation with hundreds of thousands of various posts on Instagram, TikTok, and influences normalize aesthetic procedures. And hence women start thinking about looking for them. And labiaplasty searches in SA have grown exponentially in the last 6 years or 8 years since we've started monitoring it in my practice. There's also big fashion trends, so women remove their hair. So what they have not seen before or had no meaning whatsoever now is all exposed, and hence labia that were covered by hair did not make any difference to anyone in the past, and now it's a big problem. And they think it's a disease and it's got to be sorted out. So that's another reason. I'll show you a few numbers. So this is Instagram worldwide to 2025 versus prior years. So Mommy Makeover hashtag is used in 1.6 million posts. Vaginal rejuvenation in 187,000. Labioplasty 96,000. Vaginal tightening 79,000. Cosmetic gynecology 38,000. Aesthetic gynecology 17,000. Google search in South Africa, so it's monthly average in 2025. Vaginal tightening searches is about 3,200, labioplasty 1,600, vaginal rejuvenation 1,000, vaginal tightening 290, and labia fill is 60. So it's a huge amount. It's also interesting to see how many papers we can find at the same time on PubMed, and PubMed would be where I would go to look for evidence-based data. And so on Google results, we have, you can see over 3 million vaginal tightening posts, and on PubMed, we have 167 studies. And labioplasty, we have over 4 million posts, and on PubMed, it's 1,480 papers. And there's huge gap here. Like, the gap is unbelievable. Hence, if we don't do it, the influencers will take care of it, and the aesthetic clinics will help the influencers, which is dangerous, to say the least. So now we go to the evidence and clinical statements. So the American College of Obstetrician and Gynecology has published a statement in 2007, which was updated in 2024 on aesthetic services, and what they have described is scope of practice, which includes more than reproductive health, and the specialities broad focus on women's health may include aesthetic services. Obstetrician and gynecologists may provide services that fill a need not adequately met in commercial settings, or offer safer or more efficacious treatments than non-medical sites. And again, if we don't do it, people who are unskilled will do it. Equivalent competence, obstetrician and gynecologist offering services typically provided by other specialists should possess an equivalent level of competence, and that would be, for example, related to labioplasties. So if the plastic surgeons were offering this procedure, and now gynecologists start offering this procedure, there is no problem, but they've got to have a training to offer it. And the same if plastic surgeons are offering vaginal repairs as a vaginoplasty, as a cosmetic procedure, they've got to have training to be able to offer it. Inquiries regarding aesthetic products and services must come from the patient, no pressure or obligation to purchase or undergo any aesthetic service. And example of that for me would be, I would never ever comment on anyone's appearance, ever. It doesn't matter if their labia is 20 centimeters long. It's got nothing to do with me. Unless they're coming to me to discuss their labia and their lengths, I will never speak about it. And if someone, and it's not uncommon in my practice for women to come and tell me that they've been to a gynecologist or GP, and they had for a pap smear, and they've commented on their appearance, and now they can't get this out of their head, and they're so ashamed. And I really find it very peculiar, because it's got nothing to do with anything. And to be honest, if someone is coming for a consultation on menopause or bleeding, I will never ever remember what their labia looked when I take a seat at the desk, and then they say, oh, by the way, doctor, I also would like to discuss labioplasty with you. It's like, oh, great, let's go back, because that's not what you've told me. And this part, there was no abnormality, so it's not memorized in my head, and I have no idea what you're talking about. So now we have to go back and look at the labia. So my advice to never, ever, ever discuss anything in terms of aesthetics unless you are asked for. Some women come and say, I'd like to make things better. I don't know what it is. You are an expert. Can you look and tell me what I should do? It's also a very tricky thing because we all want different things. So again, I manage this very gently. And I try to speak like kind of divided in small things and ask her, does this bother you? Does this bother you? Does that bother you? But not give you an idea that it should bother her. And maybe starting with the fact that it's all normal. Or you've got vaginal atrophy and we're going to treat it. But not necessarily that your skin is saggy, let's put fillers in. Because it's really something that they have to come up with and not me. And that would give them better result. If they came up with it and it's something that bothered them, and then you are going to answer the need that they have versus you introducing something that they never thought of and then fixing, and then they're not happy. So ethics and consent, patients' health, well-being and safety must be paramount, and practitioners must engage patients in dialogue about societal and marketing pressures toward unrealistic ideals. So we've covered that. So what is female cosmetic gynecological surgery? I've covered most of those, and there is lack of high quality RCT data. Most evidence is very poor. There is no standardized nomenclature for outcomes. There are complications, not many luckily, but there are complications such as pain, bleeding, infection, scarring, risk of altered sensation or pain, possible need for reoperation, and no validated tool to define normal anatomy, whatever that anatomy is, labial or. And we'll go through the classifications, but yeah, we're all different. And practitioner obligation, we must screen for sexual dysfunction, depression, anxiety, assess body dysmorphic disorder, refer for psychological evaluation where indicated, inform patients of evidence limitations, disclose personal experience, training, and surgical outcomes, and document consent, obviously. Patient assessment framework for the aesthetic gynecology practice does not differ from any other kind of framework when you're seeing a patient. Complaint, duration, functional impact, sexual history, obstetric history, previous procedures and treatments, screen for depression, anxiety, body dysmorphic disorder, relationship stability. Document anatomy, size, symmetry, skin condition, and exclude pathology such as any type of cervical abnormalities, infection, female genital mutilation, and lichen sclerosis is another category that is missed quite often. If you don't look, you won't see. And yeah, so just look. Investigations, so if it's easier to do a pap smear than not, in my opinion. So just do whatever needs to be done has to be done. If they refuse, the patient can decline because I just want fillers, I don't care about pap smear. Look, well, if they haven't had a pap smear in 10 years, you really cannot do a filler. Like you've got to convince them that you have to take a swab, you have to take a cervical cytology and look at the cervix and explain why. And I think in most cases they will understand. I mean, one of common things in gynecological practice nowadays is that everyone wants hormonal menopausal treatment, but mammograms are apparently dangerous. So like I cannot prescribe it without you getting a mammogram. And that's just as simple as that. So if they really want Femigel, they will go and do a mammogram. And of course, some of them will have cancer because we know that statistically it's going to happen. It's impossible not to happen. But what happens if they don't go for a mammogram and you do prescribe them estrogen? I mean, the tumor will grow quite quickly, so we will know quite soon. But it's not a good situation for anyone, not for them, not for the medical practitioner. Informed consent, explain normal anatomical variation, evidence limitations, risks, complications, alternatives, cooling off period. In South Africa, I don't think it's stated legally very well by HPCSA, but in Australia, it has to be 1 week between the consultation and surgery. So you cannot see someone today and operate on them today or tomorrow. In my practice, it's not uncommon for people from other countries or cities to come for surgery. And what we generally advise them, they've got to have at least a virtual consult. So then even if they still have a face-to-face consultation a day before, they have had a virtual consultation more than a week prior to that. And I just explained to them, this is the rules, this is how it works. And no one, like people actually quite grateful. People who don't have enough time to think are going to have the most regret, undoubtedly. And obviously for you, it's the most complaints and the most time wasted and the most anxiety. Refer to psychologist or sexologist if body dysmorphic disorder identified, unrealistic expectations, relationship issues, psychiatric history. I miss this. Undoubtedly, it's not an easy thing not to miss. People don't disclose their schizophrenia and bipolar disorder when they come for vaginal repairs, and then it comes out a few years later. They take a lot of time afterwards. So this is like quite serious, and be on alert, and if in doubt, don't operate or refer to a psychologist before the treatment. And it's easy to explain. It's just like, I really want you to be happy about your outcome. And I feel that talking to a professional and going through psychological part of this big procedure is an important part for you to have a better result. And or in my practice, unfortunately, I can't offer this service unless you go and see a psychologist. So there is lots of ways of formulating conversation and structuring conversation to make the patient understand that what you're offering is for a good outcome for them. Future trends. There is quite a few. So stem cell therapy has been around for quite some time. It's autologous adipose-derived stem cells given as a stromal vascular fraction. The cell-rich mixture is isolated from patient's own fat, stem and progenitor cells, parasites and growth factors, and it's used for tissue regeneration, elasticity, and vascularization. And it can be used in labial filling or even vaginal canal filling during the vaginal repair or without it for vaginal tightening. Exosomes for tissue repair. I've got a few slides on it as we had a meeting where the girls wanted to discuss exosomes and peptides, and it's something that everyone talks about. So I'll get to it in my next slide. AI and imaging. Look, I don't use any, we use a lot of AI in like consultation recordings and so on. We don't really use AI currently in the aesthetic practice or in the gynecological practice that I can think of. There could be something that I'm not thinking of, but it is AI. But there will be more and more coming up, and in terms of imaging or treatment planning, 3D pelvic floor mapping to personalize interventions necessary for the clients. And the most importantly, I'm looking forward to shift from the anecdotal outcomes that we're practicing, basing our practices on, to randomized controlled trials, meta-analysis, and standardized practices, and us having more evidence to base our treatments on and our offering on, and there isn't a lot available. So exosomes, they are tiny cell-derived vesicles carrying proteins, lipids, and microRNA, the body's cell-to-cell signaling system, Most products are cell-free and they're harvested from umbilical cord or placental stem cells. Underlying biology of exosomes is very well established and mechanism of action is strong and it's not in the dispute. We know it's a part of the biology, it's a basic systems that are there. The hype or the promise of exosomes, they carry stem cell repair and anti-inflammatory signals without live cell risks. They are stable, low immunogenic, engineerable for drug delivery. But marketing runs far ahead of data. Facials, hair, and ovarian rejuvenation sold very widely, and the claims frequently cite animal studies as if proven in humans. Regulators have warned against unapproved products and reported infections. So the bottom line is it's a great product, but we don't have it. And we don't have a data on it. In aesthetic practice, topical and injected products for skin rejuvenation, wound healing, and hair loss are heavily marketed, mostly not approved drugs with no standardization of content or dose. Small, uncontrolled studies, sterility and contamination risk with unregulated products. Prefer regulator-cleared products and tell the patients that benefit is unproven. In gynecology, active research is in premature ovarian failure, premature menopause, thin endometrium, and uterine adhesions or Asherman's, and IVF support. There is no approved therapy for any fertility or gynae indication. There is a couple of trials that have been registered, and we're still waiting for the results. Should we be using exosomes? But in the last Aesthetic Gynecology Congress I was at, which was 2 years ago in Istanbul, there were lots of talks on it and lots of hype about it for vaginal rejuvenation, so for GSM, for your vaginal atrophy. We do use it in the aesthetic practice just because people are asking for it, and the results, I'm not sure. Here you go.
And also because it also, especially with microneedling treatments, it minimizes the downtime significantly. So a lot of people that need the deeper sessions of the microneedling really enjoy them. And also because the skin recovers quite smoothly than usual, and they often need less home care than they would traditionally with the microneedling. So with most of the clients that we've seen for exosomes, in fact, I've seen more clients that had much more negative connotations toward microneedling because of the downtime, because of the aftercare. But with the exosomes, they now look forward to their appointments because of the experience during and after the treatment. So, yeah.
Sorry, I'm not sure if I'm allowed to ask this, but
you can ask anything.
Sorry, like what brand, is it manufactured exosomes? Or I have seen actually another aesthetic practitioner that basically did PRP, and then she had another machine that she basically used the patient's PRP and then got the exosomes from. So is that what you guys are doing? Or I've also seen another brand, Zomage, that's exosomes that they're using, but it's mostly like for hair and face and things. So I'm just wondering, like, what are you using?
So let's do all the brands tomorrow.
Okay.
We'll show, because you will be in the office,
Okay.
so it will be easier for us to show you,
Okay.
and then you will get the information with the reps details for all the brands, including this. And no, we don't mix, but not because it shouldn't be done. I think as a gynecologist, practicing aesthetic gynecology, I'm quite conservative, and I'm already outside of evidence and the guidelines. So, and I'm getting results with what I have. So for me to introduce a new product, I would have to have a reason to do so. And for now, I haven't had a reason, but maybe in what I haven't tried it in, but I think maybe I should, would be in a severe vaginal atrophy with combination of vaginismus. If the recovery is quicker for people who cannot use hormonal treatment vaginally or reluctant to do so, maybe trying vaginal exosomes would give a better result. The problem with all the vaginal preparations is burning and irritation, and it would depend what the exosomes are mixed with, because the irritation is not from the active product, it's from the actual gel and stabilizes in the gel. So one would need to try it. I'm not sure if we have vaginal exosomes preparation. I don't think so. So we'll have to look for it. But there is a company that has been on the market for many, many years, and they have growth factors. And it did not give results that were in any way superior to standardized treatments. And that product, like, it just didn't move on the shelf, let's put it that way. So we did not even, okay, is there anything else I can move to peptides? That's another, does anyone use, not in this room, I can guess no one is using, right? Peptides, it's very unusual. Because, yeah, anywhere you look, everyone is on peptides, it's not disclosed. So what are the peptides? They are short-chain amino acids, and they are body's signaling molecules, hormones and growth factors. Insulin and oxytocin are peptides. The word covers three very different groups: approved drugs, and they're prescription drugs, and then doctors administered drugs. Cosmetic peptides, and unapproved wellness peptides that you get at the gym or online, and it gets delivered into your mailbox. And it's very common, like super common. I don't know about Durban or Eastern Cape, but in Cape Town, everyone is on peptides. How's your peptide situation? No? They are. And you can see when they, it's like, it's not hard to guess, it's quite obvious. I'd like, in fact, I haven't looked for this, maybe this information is available. I'd like to know what is the rate of osteoporosis in people who take peptides. That's my one question that I have. And simply just by looking, it's not, my question is not particularly scientific. It's just by looking at people, because they definitely move themselves into that risk category very quickly. So evidence, treating them as one category is a main source of confusion, and because much of the evidence depends on the specific peptide. There is three types of evidence: approved drugs, which have very strong evidence, and that's your insulin, GLP-1 agonist, GnRH analogs, and bremelanotide. Cosmetic or oral peptides, very modest evidence. There is a meta-analysis published in 2025 with 26 RCTs, 1,721 people. And research or wellness peptides, no evidence, or very weak and early evidence. I'm not saying we're not going to have evidence in 5 years or 10 years. I'm just talking about what is available today. So the evidence for BPC 157 human data are trivial, and there is a 16 patients report on knee injuries recovery and small pilots. There is no FDA approval for those users. In aesthetic practice, topical and oral cosmetic peptides, and it's Metrexyl, copper peptides, JHK copper, argireline, have the best evidence, but effects are modest and gradual, and injectable BPC 157, CHGC 1295, plus ipamorelin and TB500 are largely unapproved. Unregulated supply carries purity and sterility risk. Cosmetic formulations are reasonable adjuncts, and consent that injectable benefit is unproven. In gynecology, we've got peptides already underpinned in co-gyne medicine that we've mentioned, and there is Vilisi is FDA approved for hypoactive sexual dysfunction disorder in premenopausal women with modest benefit and high profile of risk and side effects, 40% nausea. Compounded and nasal forms and wellness, libido, or hormone optimization peptides are off-label and not validated, so we can only really lean on approved drugs. And this is a poem that I like a lot that describes the old age. I cannot see, I cannot pee, I cannot chew, I cannot screw. Oh my goodness, what can I do? My memory shrinks, my hearing stinks, no sense of smell, I look like hell. My body is drooping, I've trouble pooping. The golden years have come at last, and the golden years can kiss my ass. But all of those complaints I certainly hear in my office on a daily basis, and it's clear from this poem that this is part of physiology and not necessarily pathology, but we of course cannot accept it and have to treat it. And so I've got reference at the end of the slides, and that's it for the overview of aesthetic gynecology.